Welcome to the Deep Dive, your shortcut to being truly well-informed. Today, we're plunging into a world where every second counts, major trauma. Imagine the intensity, the split-second decisions in an emergency, that race against time where every minute literally means life or death.
It's incredibly high stakes.
Exactly. And in those moments, there's a drug, tranexamic acid, TXA, that's become a real hero. It's an antifibrinolytic, basically. It stops clots breaking down too fast, helps control massive bleeding and trauma. It's used everywhere to improve survival.
A cornerstone of care, really.
For years, the wisdom, the guidelines, they've all said give TXA within a golden window of 3 hours after the injury. That came largely from a huge study, right? Courage-2.
That's the one. Courage-2 was massive, yeah.
But here's the thing. The sort of aha moment we're digging into, new research isn't just tweaking that time frame. It's suggesting it might be way, way short.
Critically shorter, potentially.
Yeah, like maybe only a third of that time. It's a potential paradigm shift. So our mission today is to unpack this new evidence, understand why things might be changing, and what it means for saving lives after trauma.
Sounds good.
We're looking at a new paper in the Annals of Emergency Medicine. It's an analysis of the PMID trauma trial and also a piece called Trauma Hemorrhage, Rethinking Tranexamic Acid Timing. So let's get into it. Okay, before we hit the new stuff, let's just quickly level set. TXA, why is it so important again?
Right. So as you said, it's an antifibrinolytic. Think about it like when you get injured, your body makes clots. But in really severe trauma, sometimes the body goes into overdrive and starts breaking those clots down too quickly. That causes more bleeding, which is obviously life-threatening.
Okay.
TXA steps in and sort of puts the brakes on that clot breakdown, stabilizes the clot, giving the body a chance.
Got it. And that 3-hour guideline we mentioned, that traces directly back to CRHH too.
Exactly. Courage-2 was this huge international trial. It found giving a gram of TXA up front, then another gram infused over 8 hours, significantly cut the risk of dying within 28 days.
Okay, so pretty clear benefit.
Yeah, but here's the nuance. An exploratory analysis, digging deeper into their data, showed that while it helped up to 3 hours, the biggest benefit was actually within the first hour.
Ah, okay, so even then there was a hint of earlier is better.
Definitely. And crucially, something unexpected popped up.
Yeah.
It looked like giving TXA after 3 hours might actually be linked to worse outcomes, increased mortality.
Wow. Okay, so that's concerning. And Courage-2, that basically set the standard globally then.
Pretty much. Those findings were hugely influential, adopted into trauma protocols worldwide.
But you mentioned a key detail about Courage-2. The timing wasn't exactly precise, was it?
No, and that's become a really important point now. Courage-2 was mostly hospital-based, often in lower or middle-income countries, and the time of injury. It was based on the estimated number of hours since injury.
Estimated. So potentially quite rough.
Could be, yeah. Relying on someone's guess or memory, especially in a chaotic situation, it raises questions about how accurate that 3-hour cutoff really was.
And maybe that lack of precision is why other studies haven't always found that same 3-hour effect. I'm thinking of the STAMP trial.
Right. STAMP is interesting. Overall, it didn't show a clear mortality benefit for TXA across the board.
Okay.
But when they did a post-hoc analysis, looking back at the data specifically for timing, they did find a significant survival benefit if TXA was given within 1 hour.
1 hour again. That really points towards a much tighter window, doesn't it?
It certainly adds to the evidence suggesting that, yes.
Which brings us perfectly to this new research, the exploratory analysis of the PATCH trauma trial. This seems designed to nail down that timing question. What were they looking for specifically?
Exactly. Their goal was clear. Figure out if 28-day mortality changes depending on exactly when the first dose of TXA was given, and try to pinpoint that therapeutic window more accurately.
And how did they do it differently from Courage-2?
Well, methodology is key here. PMID trauma enrolled over 1,200 adults with major trauma who were suspected of having trauma-induced coagulopathy. That's the clotting problem after injury. They were randomized to TXA or placebo.
And the timing.
This is the crucial part. They recorded the exact time of injury and the exact time of drug administration, down to the minute.
Wow.
Recorded right there on the ambulance sheet in the field. And this was done in advanced trauma systems, Australia, New Zealand, Germany, places with typically rapid pre-hospital care.
Okay, so much more precise data. And what did that precise data show? This is the big reveal, isn't it?
It really is. The core finding was stark. The risk of death within 28 days increased the longer the delay before getting that first dose of TXA.
A direct relationship. The longer you wait, the worse the odds.
Pretty much. And the headline number is this: The benefit of TXA was strongest, most pronounced, up to 90 minutes post-injury.
90 minutes, not 3 hours.
90 minutes. In that window, TXA significantly cut the risk of death. Mortality was about 17% in the TXA group versus 25% in the placebo group. That gives you an adjusted risk ratio of 0.64.
Which means roughly a 36% lower risk of death if you get it within 90 minutes.
Exactly, after accounting for other factors. But here's the flip side. Giving TXA beyond 90 minutes showed no significant decrease in mortality. The adjusted risk ratio was 1.04, basically no benefit.
No benefit after 90 minutes.
And there was even a suggestion, though not statistically rock solid, that giving TXA more than 120 minutes, so 2 hours after injury, might have had an unfavorable effect, increased mortality again.
Wow. So a much shorter window and maybe even harm if you're too late. Did they see any difference in other complications like clots?
No, that's also important. They didn't find any evidence that the timing affected things like dangerous blood clots or sepsis rates.
Okay, so it seems focused purely on that early survival benefit. This is a huge shift.
Yeah.
Why the difference between CRH2's 3 hours and Patchett's trauma's 90 minutes? Is it just the better timekeeping?
That's almost certainly a major factor, maybe the biggest. Exact times versus estimated hours, that's a world of difference in precision.
Makes sense.
But there are probably other factors too. The patient groups might have been different. Patchett's trauma specifically targeted patients at high risk of that trauma-induced coagulopathy.
So maybe sicker patients to begin with.
Quite possibly. Nearly 70% had very low blood pressure, indicating severe shock, and over a third had significant head injuries. They might represent a more severely injured group than the average patient in CRASH H2.
Okay.
And also, remember, CRASH H2 included patients who got TXA up to 8 hours after injury. Patchy trauma focused on earlier administration. Including those later patients in CRASH H might have kind of muddied the waters on the early benefit.
Right, diluted the effect.
Yeah.
So the obvious question then is why? Why might giving TXA late be less helpful or even harmful? What's the biology?
Yeah, that's the million-dollar question. And honestly, the exact biological reason is still described as elusive.
Ooh.
We don't have a perfect answer yet. But there are theories, mostly from preclinical work, animal studies, and lab models. The idea is that the body's response to massive trauma changes over time.
Oh, so?
Well, initially the body tries to clot, but after a while, especially with severe injury and shock, the system can kind of flip. It might enter a state where it's actually promoting clot breakdown, secondary fibrinolysis, and inflammation ramps up.
Okay.
So if you give an antifibrinolytic like TXA, when the body's already in that profibrinolytic state, you might actually disrupt a complex process in a bad way. It's speculative, but it suggests timing is critical to hit the right physiological state.
Fascinating. So bringing this back to the listener, what are the big takeaways here? What does this potentially mean for trauma care on the ground?
The clearest implication is that this optimal window for TXA might really be within 90 minutes of injury. That's a much tighter time frame that we've been working with. And this finding, well, it really warrants discussion, as the researchers put it. We need to seriously consider updating global guidelines and treatment protocols based on this. It could mean pushing even harder for super early administration, maybe even more focus on getting it in during transport.
It feels urgent. But you mentioned earlier there's a crucial nuance here, something about long-term outcomes.
Yes, and this is really important not to gloss over. While PATS-H trauma showed early TXA saved lives at 28 days, which is huge, it did not find an improvement in overall functional outcomes at 6 months.
Meaning
That many of the people who survived because they got early TXA were still facing severe disability, needing a lot of care 6 months later.
So we're saving more lives, but maybe not always restoring quality of life to what it was. That's sobering.
It is. It forces a conversation about the goals of care. And we also have to acknowledge the study's other limitations, of course.
Like what?
Well, most patients had blunt trauma car crashes, falls. The results might not apply perfectly to penetrating injuries like stabbings or shootings. Also, this timing analysis was exploratory. The trial wasn't originally designed with the statistical power just for this specific question.
So it needs confirmation.
Exactly. And there could always be other factors, unmeasured confounders that influence the results. So the authors are clear. More research is needed. Pooling data from different trials could be really valuable here to clarify these optimal windows.
Absolutely. Well, this has been quite the journey. We've gone from a widely accepted 3-hour golden window for TXA based on CRH2 to facing evidence suggesting a much tighter, potentially critical 90-minute window driven by the precise data from PATS-H trauma.
It really highlights how science evolves, doesn't it? And how something seemingly small, like how you record time, can have massive implications for guidelines and patient care.
Truly dynamic. And building on that, as you pointed out, we see TXA boost short-term survival, but maybe not long-term function in these severely injured patients, which leaves us and you, the listener, with a really important thought. What does this tell us about the broader goals of trauma care? Is survival, that initial win, enough? Or does this push us to think more aggressively about what happens next, about early interventions, integrated care, rehabilitation, focusing not just on saving the life, but also maximizing the quality of that life long-term?
A critical question for the future of trauma care, definitely. Something to mull over.
Indeed. Food for thought until our next deep dive.